Welcome to the MultiCultural Mindset broadcast. Your host is Dr. LaVerne Collins, a licensed professional counselor, award-winning trainer, and keynote speaker. Dr. Collins is the author of Overlooked: Counselor Insights for the Unspoken Issues in Black American Life. Dr. Collins has also been a featured monthly columnist in the American Counseling Association's Counseling Today magazine with her Honoring Diversity column. Now, here's Dr. Collins.
Hello, practice community, counselors, social workers, pastors, anyone joining in. Welcome to this episode of the Multicultural Mindset. This is a place where we explore things related to faith and culture and trauma and race as it relates to the mental health of people of color and other marginalized groups. I'm your host, Dr. LaVerne Collins. Always glad to have you join us for these podcasts. Our goal is to help you grow out of things that are not serving people of color well. Oftentimes, we just go with what we know, and we really need to pay attention to whether or not what we have been doing is serving those who are already marginalized or racialized or oppressed. So I'm committed to doing that. And today I am talking with Dr. Kristy Christopher Holloway. This is part 2 of what began the last episode, an amazing conversation about maternal mental health for people of color. I will encourage you, if you did not catch last week's episode, go back and watch part 1, because we've talked about the conditions, the situations, and the place in which women of color, especially Black women, find themselves in where they find themselves in trouble, really, in crises, because of things like medical racism and whatnot. And Dr. Holloway is the expert on such issues. She is the founder and director of New Vision Counseling Center and New Vision Consulting and Training, both located in Georgia. She is a leader in our profession. She is a guru on this topic of perinatal mental health and all issues related to infertility trauma, birth trauma, reproductive loss, and so much more. A leader in our field, leadership in many organizations. So I'm delighted, I'm honored to have her in this conversation with me. So welcome back, Dr. Kristy Christopher Holloway.
Thank you. Thank you for having me back. I am delighted to be in your space as well, and to really provide this information to your listeners. So thank you so much for this topic. And thank you for asking me to be here.
Well, thank you. This is an important topic.
Yes.
Because we have to understand, as human service professionals, counselors, et cetera, we have to understand the lay of the land when it comes to this pandemic, as you described. It's an epidemic of maternal losses and health challenges and mental health challenges. So, listeners, go back, watch last week's episode, either before you do this one or right after. Either way, it doesn't matter. But we want you to catch both of these so you can get the full benefit of Dr. Kristy's knowledge. So I'm going to dive in today with this question, because you did a wonderful job in the last episode of helping us understand the systemic factors, the health disparities, the role of socioeconomic status, which there really surprisingly is none, but the things that impact Black maternal mental health. Let me start today by asking, what are some culturally responsive strategies or interventions that can better support Black mothers experiencing mental health struggles?
Absolutely. Wonderful question, right? Because, we talked last time about just all of the issues that are there. But one of the things that I tell my students, my trainees, supervisors, all of that, colleagues, don't talk about it. Don't just talk about it, be about it, right? So how are we being about this work that we should be doing or that we're hoping to do? So I think one of the first culturally responsive strategies and interventions, we have to take a step back and look at how are we training providers, whether that's a mental health provider, whether that is a medical provider, anybody that really works with birthing people, right? How are you being trained? Doula, lactation, any of that. How are we training our providers? What information? Are we still teaching from books from 20, 30 years ago?
Oh, God.
Right? Are we still teaching? I tell my students, I'm teaching you these theories. What does this theory have to do with right now? Can we still use some of those? Absolutely. But how do we adapt those and modify those for particular populations that we're working with? So I think the first thing that we have to look at is how are we training providers? How are we training professionals? Are we looking at and making sure that we are coming from an anti-racist or anti-racism lens? Are we coming from a lens that shows cultural humility? So a culturally informed, a trauma-informed, an anti-racist informed lens so that we can improve maternal outcomes and maternal mental health outcomes. Because again, they go hand in hand. If I am experiencing birth trauma or my doctor's been yelling at me or telling me you better push before I cut this baby out of you, you don't know what that's bringing up for me. Right? Or examining you without giving you information of why they are examining you and how, right? Did they ask for permission to touch you?
Touch you.
Did we even, let's start there. Hey, I got to come in, do this exam to check on you and baby. Is it okay if we proceed? I mean, we teach children that good touch, bad touch, not that it's a bad touch, but did you even ask for that permission to proceed and touch me? Do you know my history? And maybe you don't, right? Maybe you don't know if I've had some abuse history, if I've had a past with any of this. You may not.
Assault. Yeah, lots of things.
And if you didn't, what is that bringing up for me? So if that care is off, my mental health, right, may very well be impacted. So how are we training all of these providers that are working with birthing people? I think is going to be the first part. Also increasing the number of Black and brown or I get caught up on the term BIPOC because I think it lumps everybody in and we don't say those words, but Black, Indigenous, Asian American, Native American, right? How are we making sure that we have those providers? What are our learning institutions doing to make sure that we get those students so that we can push them out as providers? If we aren't recruiting, and I know it's a lot of changes going on administratively wise within our country, but how do we do that to make sure when we say representation matters, that it's just not a tagline?
That's right.
Buzzwords to say that we are really meaning that it matters because folks are typically going to go where they feel safe, they feel seen, they feel heard, they feel connected and trusted. That's what to happen. So how are we making sure that we are having the therapists that we need, the doulas, the midwives, so that we can provide culturally congruent care? I think is very critical. Peer support, community-based programs are going to be important. Everybody's not going to go to therapy. Everybody's not going to, whether they want to, or whether they don't want to, or they can't, right? Because of some of those barriers that we talked about. Whether it's because of stigma or if it's just maybe I don't really need a therapist, I just need a group, right? I just need some folks. I need to find community. So having different community-based programs that are out there that can offer culturally relevant maternal health resources, I think is important. Community-based support groups that will work to reduce a lot of the isolation that I think people of color experience and a lot of the stigma that's around healthcare and mental health care. I just had someone talk about just some things that they were experiencing. And because the provider was not culturally informed, they were about to diagnose this person with schizophrenia. And so, why am I going to go to a provider who is not informed enough or won't even just ask me about some? If they would have honestly asked them about some of their practices, and beliefs, they would have understood that, hey, this person isn't hearing things, or this person isn't paranoid, and this is a cultural belief system.
Yes.
So even the respect that has to go there. So I think that's important. And then just having holistic and alternative approaches. So is that yoga? Is that meditation? Is that faith-based? I ask my clients all the times, what are those support systems or those things that are important or indigenous or traditional to you that you want to incorporate in the work that we're doing? So if I know that you speak to the ancestors or you connect with the ancestors and that you have an altar in your home, guess what my intervention is going to be? I'm going to use that.
Yes.
What I'm going to do. If I know that you are going to pray, I'm going to incorporate that. That's going to be an intervention. If I know that you like art or gardening or sewing, that's an intervention. Right. So using those different methods are going to be important, making sure they are culturally informing. And then, just as I said, that education and advocacy. So teaching Black mothers and mothers of color how to advocate for themselves in medical settings, how to request their records, how to move and find you another provider if that provider is not doing it for you. And then just really normalizing and even commonizing some of the conversations about mental health in family, families of color and in communities of color too. I think all of those are some of those steps and culturally responsive strategies that we can implement.
Those are excellent ideas. Wonderful, wonderful ideas. What do you think about referral systems, referral agreements between OBGYN providers and mental health providers?
Absolutely.
Should mental health providers be out there leaving some business cards and making connections?
Yes, yes. And, not just on mental health, all the providers, again, how are we connecting? How are we building a mutually collaborative relationship? So here's the thing. I mean, at least in my training and folks that I've worked with, and I've trained medical doctors, psychiatrists, social workers, therapists, doulas, lactation dentists, all types of folks. And none of them have told me that their code of ethics or their practices or things like that don't say do no harm. Right? They don't say that. That is a thing. So
they all say that. Yeah.
Said, or however it's stated, there's that implication of benefiting the client and doing no harm. Also treating the client. And so if I am not treating you holistically, how am I really treating you? I'm not. Right? So if you are a therapist, you're not, and this is a population, regardless, whatever population you work with, right? If you're not connecting with those other folks that are also working with that population, are you really benefiting your client? Are you providing them the holistic care, or the quality care, or the comprehensive care, right, that they can really be getting? And it's a lot because we're already stressed to the max. We have poor insurance reimbursement for those of us that accept insurance. You're trying to see so many clients because you're trying to keep your family fed and your lights on as well, right? And so it does seem like a lot. Like, wait, you want me to also go out here and connect and collaborate and network and market and all the things? Yes, right. But there are ways that can look. Can you send a letter? Is it your own OB, right? Or your OB guy? Can you leave information? Hey, this is a population that I work with. If you have children already, you're picking them up from the daycare. Can you leave your information there? If you are religious or spiritual and you attend a faith setting on Friday, Saturday, Sunday, whatever day it is, can you leave that information there as well? I have left business cards at the chiropractor, at restaurants that sometimes have like a little area for business cards, at the library, at the gym, that they'll have up there. So yes, connecting with your faith leaders, right, in the community, because this is also what happens. May and June, Mother's Day and Father's Day. And typically what happens, we start seeing all the billboards. We start seeing you think about people, you're just going on and you see a Pampers billboard or commercial and you just had
Mhm.
a loss, right? But this is what happens, and especially in the Black church, Mother's Day, all the mothers stand up. We want
Oh,
to honor you and acknowledge you. And you don't know that your member right now is going through a miscarriage, literally right now. And they were already struggling if they wanted to come to church or not. And you
see,
just said, stand up. And do
right.
I stand up or do I not? Because I've had several losses, but then people are going to say, but where's your baby? Or how many children do you have?
You don't have any children? Right.
Right?
Mm-hmm.
To the dads, I didn't know you. How is it a son or daughter? Right? Because
Yeah.
so some people still will say, yes, I'm a parent. My child is not earthside, but I am a parent, right? Some may not because they don't know how to reconcile that.
So-
But this is what happens. And then we're wondering why your numbers are low during these months at church.
Uh-huh. Mm-hmm.
I
Mm-hmm.
am not I don't feel safe. I don't feel welcomed. I don't feel, whatever it may be. So, yes, leave this. This is how we can educate those faith leaders. This is how you think about going into your OB-GYN's office. And if I just had a loss and I'm coming in for that checkup, right? But I'm also sitting in the waiting room with pregnant people.
Looking at, yeah. Yeah.
Or they
Looking at women who are carrying.
How
Yes.
do we do that, right? This is a population that I work with, and I may have a client that's had a loss and also a client right after them that just had a baby. Are their paths going to cross in that waiting room, from one leaving and the other entering? How do I preemptively think about how to manage that and navigate that? Right.
Yeah.
So, yeah,
Yes.
to answer your question, yes, we should be connecting with other providers if this is the population because they need to know. And in my research, um, I've done research on infertility in religious and Black, religious or spiritual African American women. I've also done research in Black couples that have experienced infertility and a perinatal mood and anxiety disorder. And both of those, what was said is I didn't even know who I could go to. I didn't know that there was a therapist that dealt with infertility.
Mm.
Oh, that it was even a thing. I knew that I could go to therapy for substances. I knew I could go to, and one lady said I even had a referral sent to me because I had some back pain and a pain management therapist, right? But no one ever told me that there was a therapist that supported infertility, which if if your listeners have heard our first podcast, right, we talked about infertility being a risk factor for perinatal mood and anxiety disorder. So your providers may not even know all of these risk factors. If you're already working with a client that's experiencing trouble getting pregnant or lost, yes, you need to have a business card there to refer them. Hey, they may also experience some postpartum depression. Yes, even though you don't have a baby right here in your arms, this is still postpartum or this perinatal period, right?
Mm-hmm.
Depression, anxiety, trying to get pregnant again. Do I get pregnant again? Do I tell family? Do I not tell them? When do we start again? Is it too soon? How long do we wait? Do I have time to grieve? You
Yes.
mentioned my fertility journey, and I remember when those moments it didn't work. But day 3, soon as your cycle starts, that period starts, hey, I got to call the doctor because day 3, I got to get up here. So there's no time to
Mm.
even grieve that my period has started and that we're not pregnant this month because I got to keep going and keep going if I want to make this happen, right? And
Mhm.
all of the tests and then waiting on the calls. And this is why I say that infertility can be very traumatic because all of the things that you're doing, right? So yes, your doctor needs to have a referral to be able to, they need to be educated, one, on perinatal mental health, and then have resources. And the only way they're going to get that is if we're out there, we're all making these connections and collaborating.
We have to be out there and we have to be working together. I love that. I love that. You gave such wonderful examples too. Great examples.
And
Um,
before COVID, LaVerne, before COVID, I mean, I remember, oh, let me go here, let me go out here, let me take this, let me take some brochures, let me take some cards. And I would always, because most practices are busy. So when is a good time for me to come drop this by, right? And
mhm.
maybe meet the office manager. But we have a new generation where we had this generation pre-COVID, and then COVID hit, and don't nobody want to talk and interact and go out, right? So, but can we make those quick virtual coffee chat meetings, right? 10 minutes of your time. Can I still mail out? We can still mail some business
Still
cards,
mail
brochures,
things.
and a letter about who we are and what we do, and then follow up. We can call that office, because it may not honestly be the doctor that you're going to talk to, it's their office manager. So let me get the name of the office manager. Hey, Miss Susie or Mr. Mike or whoever, can I send this to you? And you share that, because they're the ones who's creating that referral list, letting the doctor know and things like that. So just taking that extra time to make sure we're doing that can be helpful.
Yes. Now let me tag on something that is related to that.
Okay.
We need to make ourselves known to the provider community.
Yeah.
But we also know that there is a big problem, or not even I won't say a problem. We know that people of color often have histories of trauma, racial trauma, medical trauma, et cetera. And there's often not a lot of trust in counselors, behavioral health providers, et cetera. How can mental health professionals, as well as healthcare providers, work to build trust so that we can help improve mental health outcomes for Black birthers?
Absolutely. One way is to have providers of color, right? Or providers that represents whatever that population that you work with. So if you are working with differently able population, why you got all able-bodied people here, right? If you're working with the neurodivergent population, why do you not have neurodivergent providers here? If you're working with the LGBTQ plus population, do you have that representation, right? So one way is to have that representation of the main population that you are working with. What does that look like? Because I see it a lot of times. Many times folks will say, well, we are diverse. Well, what does that really mean? That you have a woman on staff?
One of anything does not a diverse organization make. One person with one unique identity is not.
I'm like, wait, y'all got an award for diversity. Where is the diversity? But okay. Or how are we defining, right, diversity, right? And what does that really mean and look like? But just having that representation is a way to build trust. Can I see a provider that represents me? I have had folks come to me and say, hey, I don't care about all them little, and literally say it like this, I don't care about all them little letters behind your name and all the little things you've done. I came to you because you had locks. And I have locks.
Wow. Something as simple as wearing your hair naturally.
Yes, you have locks and I have locks. And I felt that we were going to talk. We were going to connect.
That's amazing.
First 10 minutes of every session, we're talking about hair and styles and all the things. But that is cultural humility. That's showing up. And we say these things because it gets me, and I'll get on a whole tangent or soapbox, and then this will be an hour-long podcast. But we say things about meeting clients where they are, but are we really? What does that mean? And are we really doing that? And if my client needs to talk about locks before they can now start talking about their loss, guess what we're going to talk about, right? Because they're building that trust. They are building that, we are building that rapport, and we're showing them that we're human too, and that I see you and I can meet you for wherever your comfort level is right now. Right? Some clients do want to know how long you've been in school. Do you have a PhD, a EDD, a PsyD, or who your mama now? Like all of that things too. Like some clients, that is extremely important for them too, and they do want to see all of those letters or education and things like that. So I'm not knocking that. I'm just saying what is important to the client. How do we have that represented and shown in our spaces? That is a way that we can increase that trust or to build that trust. Also, since we are specifically talking about maternal mental health and perinatal mental health, because I always like to emphasize that too. When we just say maternal mental health, it will lead us to think that this is only something that birthing people, women, experience. have to understand is the birthing person's experience with perinatal mental health increases the non-birthing person's experience in a perinatal mood and anxiety disorder too. So if I just speak from a heterosexual couple, my experience with postpartum depression and anxiety puts my husband's risk of experiencing postpartum depression or some type of depression based on my postpartum experiences as well. So dads can, or the non-birthing person can also experience these diagnoses too. So when we just say maternal, because sometimes people don't have that knowledge and they'll think this is a hormonal issue, and it's not just a hormonal issue. We talk about cultural factors, social factors, previous losses, risk, all of these different things that can be risk factors, being in a high-risk population or group. So Black and brown folks, right? Cultural traumas, historical traumas, all of these things can contribute to the development or the increase or exacerbation of a perinatal mood and an anxiety disorder. So when we know it's not just hormonal, we know then it's just not women that can experience it. So you'll hear it, but I just wanted to emphasize that.
Yes, that's good.
Because it's not just maternal. So that's why we typically say perinatal or paternal mental health. Even through adoption, adoptive parents can experience this even if they've never birthed a child before. So I guess you'll have to have me on for a third time to talk about all of that as well.
Yes.
But yeah, so having those Black midwives and doulas, or doulas and midwives of color, to also reduce maternal mortality is another way that we can increase that representation. Building trust, again, training. Are you aware of your bias? I tell my students, all of anybody that comes across me that I'm training, we all have bias because we all have a different worldview. We were all raised differently. So it's going to be there. The key is, what is it? So knowing what it is, acknowledging it, and being aware of how it impacts the work that you were doing. Is it showing up in the work that you were doing? How do you need to check that? And if you cannot check it, or it's causing harm, coming up off your pride or whatever it may be, and referring that client out. So that is a way to build that trust. I ask all of my clients, can you tell me your cultural belief system? Can you tell me your cultural background and how that shapes your decision making? For even choosing me, even coming to therapy, because this is going to help me understand you more. No, it's not your responsibility to tell me all your culture's traumas and issues, but I need to know that for you. How does that shape our time together? That's important. And even asking that question, I've seen clients' shoulders drop, because I have to acknowledge we're different. If it's another Black woman with locks, we're different. If you're a Black woman from another country in America, you have a different experience than I do. So I have to be able to come from that lens and knowing that. And I think that is a way in building trust. So we're talking about anti-racism, bias awareness, being trauma informed and culturally informed, listening to Black mothers, listening to mothers of color. What are their concerns? Are you taking their symptoms seriously? And then, and this is a more of a legislative piece, but how can we provide longer postpartum care beyond that 6-week checkup?
We're talking now policy changes and
absolutely, because one of the things that we'll know is women, birthing people, can experience the diagnosis of a perinatal mood and anxiety disorder can come upwards of 2 years after giving birth. And
2 years.
Say longer than that, because we're all postpartum after that, right?
Right.
But I've had folks come to me and they're like, oh my gosh, I've been struggling. When did you first notice this? Oh, after my son was born. Well, how old is your son? 8. So your son is 8 years old. So what I know is this was an undiagnosed or misdiagnosed anxiety disorder that I am now treating 8 years later. So now like major depression. Now it looks like generalized anxiety or whatever that diagnosis is. But what I know as a trained professional is this was never diagnosed at that time. And they've had another baby and another baby and another baby.
Oh, so it's compound.
It can be. It doesn't always mean that because you've had an issue with your previous child that you will with this one. But when we
Mhm,
haven't, it's with anything, when we haven't resolved or worked through some of that,
mhm,
right? And so I've already gone into this pregnancy anxious or depressed or whatever
mhm,
it may be. My
mhm,
OCD symptoms may be heightened. My PTSD may be re-triggered because now I'm thinking
mhm,
about the birth trauma that I experienced, or I'm thinking
mhm.
about when that doctor yelled at me or no one came and checked on me. Will that be the same? And all of that trauma is resurfacing, right?
Yeah, yeah.
So when we just stop at those 6 weeks, some folks don't even make it to that 6 week checkup. We think about that. But if they do, who's assessing them after that? Who's checking in with them? Because most are still in that honeymoon phase. Oh my gosh, look at my baby. They're the best. My partner's the best. If they, are in a partnered relationship, everything seems, oh, I could just watch them sleep. They smell so good. They, look at
Yeah,
the little
yeah.
baby rolls.
Kind of euphoric.
All of that is still there. And then bam, 8 weeks, 12 weeks, 3 months, 6 months, when all of the support has kind of left, right?
Mhm, mhm,
Maybe if you were working, you've gone back to work from maternity or paternity leave, all of those different
mhm.
things. And I'm expected to still come in here and perform like I did before this baby or these babies and things like that. And so folks aren't knowing, which is how it can be missed because we think 6 weeks, if it's going to show up, it's shown up by now.
Ah, wow. There's so much education that is needed. Oh, and I am thankful that you are sharing from the wealth of your knowledge with our listeners. Thank you so very much. Glad you got into the policy changes because those are things that are structural and systemic within corporations, within organizations, within healthcare, within insurance. Oh, gee, yeah,
Yeah.
yeah. There's so many layers to that.
Right, because it's
Um,
only going to be so much that a person can do when you have different policies that are there
mhm,
or not there. And so then it looks, what does that even need to look like?
yeah, yeah.
Can I
People,
say something before we go to, because
please.
we mentioned you say how do we work through this? How do we do this? And I said, well, it's about training. One of the things in counselor education programs or master's programs, they're not even this is not even taught about.
I'm not talking about.
It's just hey, I finished school, or maybe I had a supervisor that was in it and they trained me in it and I knew to go get further training. But this is a thing that's not even talked about. We talk about all the other stuff briefly sometimes, but
Briefly.
it's touched on. Even if this was touched on enough to spark in students or counselors in training, doctors in training, I can't speak on all, and I can speak on some medical programs because I've had them tell me, no, this isn't perinatal mental health isn't talked about. We had 1 week or a chapter on it, and that was it. Nothing else. So no, you don't know how to screen, or to assess. You don't even know what questions to ask.
Mm-hmm.
So if you don't know how to assess for it, you don't know how to screen for it, you don't know what questions to ask, you don't know how to treat, you don't know how to refer out, you don't know how to do anything, and you have a population of people that are dying, you have a population of people that are suffering. And so I think another way to build this trust and to help reduce these disparities and these numbers is to teach about it, to actually make it a curriculum and not just an elective that you can take. Because I typically say you are more than likely going to have a perinatal client in your face.
Mm-hmm. Mm-hmm.
What are you going to do? I may not have a substance use person in front of me. I may or I may not, but I have that basic knowledge of what I need to screen and assess for
Right,
or out because I'm not a substance use professional, right?
right,
It was
right.
taught to me. Some
Uh-huh.
of these things were, right?
Mm-hmm.
But this part is not being taught. And I really think it needs to go into training programs as well.
Oh, I so agree. I can't agree with you more on that. How else do we learn if we don't have a teacher?
Yeah, yeah.
Yeah. And but that means the other thing to think about is that if if the people leading programs don't have this on their radar,
Mm-hmm.
if they're not thinking about it, the educational programs, the university programs, then it's not going to make it, not going to make it to the table.
It's not.
Um, yeah. So thank you for that too. This was a phenomenal conversation. Again, part two of a phenomenal conversation. And I can't thank you enough for sharing from the wealth of your knowledge. Clearly, I'm fortunate to know you. I'm thankful to know you because you are definitely a leader, one of the nation's leading professionals
Thank you.
talking about this, advocating for this, training, teaching, supporting. And I just wish you much success
Yes.
in all of the things ahead, that the places where you'll go and the people you'll meet and the way that you're influencing the profession and the way you are improving conditions for our communities, women in our communities. Thank you for all that you do.
Thank you so much. I appreciate that. I receive it.
Well, thank you everyone for joining in on this episode on talking about perinatal and maternal mental health for people of color. How do we incorporate this understanding into our practice? You may want to do a consultation
Yeah,
with Dr. Kristy. Will you tell us how people can reach you? And I'll also put this on the credits at the end of the podcast too.
absolutely. You can send me an email. Well, you can go to my website, Kristy C. Holloway, www.KristyC.Holloway. So that's KRISTY Holloway, HOLLOWAY. You can reach out, you can see all the things that I'm doing, where I'll be, things like that. There's a speaker request form on there. You can also email me at KristyCHolloway@gmail.com. And then I'm on the socials. So Instagram at Dr. Kristy C. Holloway, where I try to post information and things like that. Facebook under Dr. Kristy Christopher Holloway, and then LinkedIn is Kristy Christopher Holloway. So you can find me somewhere. If you can't find me through all that, I don't know what you've been doing, but go Google something. You can get to me, and definitely I welcome and I look forward, because this is a passion of mine, these two topics. And talking about this to really reduce these rates, these maternal mortality rates, increasing awareness, reducing stigma, and educating not only the population that we're serving, so those clients, but us providers and working with this population.
Yeah, I always say that a diagnosis aimed at the wrong target leads to an intervention that is really no intervention at all.
None whatsoever.
It's what is it? It's you're aiming at something that is not the right target.
Yeah.
So we want to recognize these mental health issues that are related to maternal or perinatal states. So it's important that we get it. So you'll be able, audience, you'll be able to find all those ways that
Yeah.
Dr. Kristy has said she can be reached. We'll put those in the credits right after the show ends. Thank you all again for joining us. Dr. Kristy, thank you once again. If you work as a mental health professional, I certainly hope that this helps you to be more aware, be more cognizant, to think about some of the nuances, especially when you're talking about Black birthers. If you are a member of the community who is not a provider, I hope this just encourages you to seek out what you need in terms of the people that support you in terms of mental health and maternal health, etc. As always, if you enjoyed today's episode, make sure to turn the notifications on and subscribe, leave a review, share it with others who might benefit from this information. This is LaVerne Haynes Collins and my sisterly colleague, Dr. Kristy Christopher Holloway, signing off. And until next time, keep practicing with empathy, humility, and a multicultural mindset. So long for now.
Bye.
Bye-bye.